For the n-Lorem Foundation, N of 1 doesn't mean alone because every patient matters. Hope for nano-rare patients and their families has never been more within reach. Visit n-Lorem.org today to donate and make hope possible. This episode of the n-Lorem Patient Empowerment Program podcast is proudly sponsored by Hanjin Biotech. With more than 26 years of experience in the nucleic acid industry, Hanjin is a specialized CDMO and raw material supplier committed to providing high-quality and high-value products and services with the best-in-class lead times.
Hello and welcome to the n-Lorem podcast series, a series that focuses exclusively on patients now referred to as having nano-rare mutations. I'm Stan Crook, and I'm the founder, chairman, and CEO of n-Lorem. n-Lorem is a nonprofit foundation that I initiated in January of 2020. Our mission at n-Lorem is to take advantage of the technology we created at Ionis Pharmaceuticals, Antisense technology, or ASO technology, to discover, develop, and provide experimental ASO treatments to nano-rare patients, and to do that for free for life. As most of you know, n-Lorem is celebrating its 5th anniversary, and I believe that as we experience life, the most important question we should always ask ourselves is, what have I learned? And certainly, I think that's the most important topic to consider as n-Lorem celebrates its 5th anniversary. You know, we are barely off the starting line at n-Lorem at 5 years in, but I believe what we've learned is really important. We've learned so many important lessons, and I think it's important that we share them with you. And what we've learned sets the stage to do more and to acquire even more important knowledge as we go forward. I think the knowledge that we will acquire in the coming years will change the way we think about health and disease altogether. So today, my plan is to share a bit of what we've learned. And to help me do that, I'm joined today by Andrew Serrano. Andrew works at n-Lorem and is the behind-the-mic person who has helped make this series so successful. And many of you have interacted with Andrew at the colloquium and in other venues. So Andrew will serve as a surrogate for those of you who listen to this podcast by asking questions that perhaps add clarity to what I have to say. I also hope that if you have questions or comments, that you send us an email or text, and then we will try to answer any questions that you pose, and certainly we'll be interested in any suggestions or comments that you have. Andrew, welcome.
Thanks, Dan. Happy to help.
And I'm sure you won't have any trouble jumping in and asking questions. You do it all the time. So just jump in and ask questions that you think might help clarify what I'm saying to our listeners. So what have we learned? Well, I think probably the best way to organize that answer is to break the answer into several different categories, sort of general questions about the nature of nano-rare patients, what we're learning about nano-rare diseases, the impact of ASO treatment on those diseases, what we're learning about neurodevelopmental diseases in particular, and generally what we're learning about health and disease. And since our remaining challenge really is to continue to finance our activities, what we've learned about financing and how we're feeling about our ability to do this going forward. So moving into general lessons, I think by far the single most important lesson is we can do this. We can do this. It's odd for me to have so many people seem to take for granted what we're doing. For sure, everyone I talked to when I thought about forming n-Lorem said it was impossible. You will never get the FDA to agree to this. It won't be possible to discover and develop an ASO inexpensively and rapidly enough to treat patients. These patients are too sick. You're just 1,000 reasons why people said it couldn't be done. And there were many, many people who doubted whether we'd be able to do this as a nonprofit. How can you possibly give away drugs for free for life? And so, to my mind, n-Lorem is truly a miracle. And it's a miracle that is a product of advances in science. Everyone really needs to understand this. It's really important, particularly as we face the coming years. So let me repeat it. n-Lorem is a miracle that exists only because of long-term investments in basic and applied research. n-Lorem is a miracle that exists only because of long-term investments in basic and applied research. n-Lorem is a product of the merger of two long-term investments: genomics research, which began with the structure of DNA published in Watson and Crick, and the investment in ASO technology that began in 1989. Were it not for Watson and Crick and thousands of scientists that followed them, we would not know genetic diseases exist, including nano-rare genetic diseases. And if I had not founded Ionis in 1989, and almost everyone thought I was crazy to do it then, ASO technology might not exist today. Without the knowledge of genomics and antisense technology, none of this happens. So why is this such an important lesson? Because every day, politicians, policy makers, and others must make investment decisions. And of course, there's never enough money to go around to fund all the good ideas. Should we spend a dollar on defense or current healthcare issues or natural disasters, social justice, crime, etc., or the long-term future created by science? These are tough decisions, and I certainly don't claim to have the wisdom to make such decisions, but I know this: n-Lorem exists because of the long-term scientific investment and the robust, risk-tolerant entrepreneurial environment that exists in the United States. And I would say to those of you who run into people who question the value of investing in science, and I think there are more questions coming today than perhaps in a long time, and new risks to science going forward that I'm concerned about. So I would say that n-Lorem is tangible, poignant, compelling proof of value in investing in science. Everyone interested in n-Lorem should become an advocate for science. If you don't, the future n-Lorems may not be created. n-Lorems of the future will be created by basic advances today.
I think a good example of this concept of investing in science, at least in popular media today, is SpaceX, right? It's the outcome of the U.S. government, 1960s U.S. government, recognizing that the value of investing in science by creating NASA to develop rocket technology during the space race with the Soviet Union, right? And now, since the early 2000s, SpaceX has built on that knowledge stemmed from NASA and combined it with private funding to innovate these reusable rockets and make spaceflight more affordable, with the ultimate dream of one day colonizing Mars and creating a multi-planet civilization, right? And while that may not seem like a necessity to some people today, it's a needed advancement should the human species survive in the distant future, because the sun is going to inevitably expand and hurt our civilization in the long-term future, right? On the other hand, ASOs are needed by these nano-rare patients, and the knowledge gained from these patients will continue to advance human health in the centuries to come. So, Stan, I know that you look up to the stars often. Would you agree that these ideas intersect in some way?
To some extent, yes. I guess what I'm trying to say is that there are some scientific advances that are so fundamental that they fundamentally change the way we understand our world. And that in turn changes the world, and it changes us. To my mind, the discovery of the structure of DNA was, for the biological sciences, the equivalent of Newtonian physics or Max Planck and Einstein and others developing quantum mechanics. And so if I were to take the SpaceX example and put it in the context that I'm thinking, I probably wouldn't go back to the Chinese, but I'd have to go back to 1600s. Newtonian physics was the theoretical basis of rocketry. And then to the early 1900s with Goddard experimenting with rockets here in the U.S., the German scientists that invented the V2 rocket, that's an astonishing step to take rocket fuel, turn it into a rocket and ballistic movement. That's amazing. And then, of course, Russians captured a bunch of German scientists, and that's how they got what appeared to be a lead on us in the space race. In the meantime, we invested in Vanguard, which blew up on the rocket pad repeatedly until Wernher von Braun and the Jupiter program was funded. So I look at SpaceX and I say it's an incremental step. I mean, recovering the booster and reusing it is important, but it's still using a ton of energy to get us out of the planet. And so I would say that what we're able to do today in the nano-rare patient population is the product of really earth-changing innovations. And so in that sense, if you look at the history of how we came to be capable of sending spaceships around where we want, it's much longer context. And SpaceX, in that grand scheme of things, will be considered, I think, a very tiny step, with much bigger steps having taken place. Again, I am always shocked that people choose not to know history. If you don't really know history, you live only in 2 dimensions today. And our world's 3-dimensional. We have a history of how we came to be where we are, how we came to be doing what we're doing. I think it's important to know. And for sure, as we think about n-Lorem, and we think about what we hope to do in the future, we exist in the grand scheme of centuries of advances in science. And that's the point I want to make. And if we want to continue to see those advances, we have to invest patiently in the systems that have gotten us to where we are. And I worry that we may step away from that. And if we do, I think the outcome is guaranteed, and that is we'll take giant steps backward. So I guess my point is a little broader than even SpaceX, which is an important step, but it's a step that began with Newton in the 1600s and has a rich history. Does that make sense?
It does, right? All knowledge compounds.
All knowledge compounds. Really important point. What we learn today informs what we will learn tomorrow and accelerates what we will learn tomorrow. And so that's another way of saying what I'm trying to say. All knowledge compounds. SpaceX is an example of 3 or 4 centuries of compounded knowledge. So anyway, I hope people hear me. And if you're interested in what we're doing, get out and support the idea of scientific inquiry and the idea of database thinking and knowledge, not magical thinking. So I think the second question that we've answered very clearly is, can nano-rare patients be treated safely? And absolutely yes. The answer is, if you know what you're doing, if you create industrialized systems, if you do it the right way, there is no reason for these patients to have side effects. Now, that wasn't a given. The notion of taking an ASO immediately to treat very sick patients with only cell culture data was entirely novel. And great credit goes to the FDA for issuing the guidance that supports this. This is a big step out of the norm for the FDA. And it demonstrates that the FDA is concerned about how we take care of nano-rare patients. And I think n-Lorem demonstrates that if experts in ASO technology create optimal personalized ASOs and industrialized processes, it's possible to treat nano-rare patients without imposing inappropriate risks and side effects. Why industrialized processes? Well, these are critical to ensuring quality. So while we move as rapidly as we can, I believe strongly that nano-rare patients deserve the best. And the best requires consistent industrialized processes run by people experienced in the technology and experienced in drug discovery and drug development, in my view. So I think the third general lesson is that the nano-rare patient population is very large. Now, because only a tiny fraction of humans have been genomically characterized, and really you need whole genome sequencing. We really have no idea how many nano-rare diseases, how many nano-rare patients exist. That said, based on the demand that we've experienced, there may be thousands of nano-rare diseases, and certainly there are millions of nano-rare patients. This means that as the scale of the nano-rare problem emerges, we will understand that nano-rare patients are imposing enormous costs on our healthcare systems, and that effective treatment would be the only way that those costs will be reduced. And I hope that n-Lorem will lead in that process, because we're demonstrating that treatment makes a big difference. And the more nano-rare patients are identified, the more pressure on the healthcare system to be responsive to their needs there will be. And I hope that n-Lorem can be in the vanguard of that.
Right. So you're saying that treating nano-rare patients with ASOs is more cost effective than if they were left untreated, because they would have more frequent visits to the hospital. Is that right?
I'm saying more than that. I'm saying that diagnosis saves money. There's nothing more costly than misdiagnosis and mistreatment, and effective treatment saves money. But more than that, what we experience is that in almost every family with a nano-rare patient, at least one wage earner has to stop working. And so we will save healthcare dollars, and we will return productivity to the workforce. So I think the savings are difficult to calculate, but I think the cost of nano-rare patients today is enormous, and reducing that cost with effective therapy, freeing up family members to go back to work, to have a life, is very important. And I think it's way more than that. Yes, there's a cost, but the cost is also emotional and very human. And so while we can think about reducing the cost to healthcare and improving our overall cost of living and quality of life, what really is at issue here is our lives. Nano-rare mutations destroy families, and we need to stop that. It's worse than just a patient. It just imposes such demands on families that it's heartbreaking to watch, and we need to address it. So yeah, we're very aware of reduction in costs and improvement in productivity, but we think saving a life and saving a family is not measurable in dollars in the end. You ask also, what about the long-term potential of a human being who otherwise would have no potential? How many Einsteins and Max Plancks and Watson and Cricks and so on might we discover? How many great musicians might we experience? How many great leaders? I think about all the patients who are growing up who are alive and doing well was because of Spinraza, all the SMA patients, unlocking all that potential. How do you calculate the value of that? It's incalculable, but it's important. So I think another big lesson, obviously, we keep hammering this home. We must introduce genomic sequencing into newborn evaluation protocols. Only with the introduction of genomic sequencing in all newborns will we have any idea of the scale of the nano-rare problem. Will we eliminate the long and perilous and costly journey to diagnosis and be able to introduce treatments of these patients before the disease becomes so severe? It is remarkable that we're seeing the benefit that we're seeing in patients who have such advanced disease. And that should encourage us to get to work, to get to these patients earlier. And we can only do that if we have a genetic diagnosis. And so if you're interested in what we're doing at n-Lorem, write your congressman today to demand genomic sequencing be introduced to newborn screening protocols. It's happening around the world. It's happening last in America, which is a terrible statement. And it puts us at a competitive disadvantage in terms of reducing long-term healthcare costs and understanding health and disease. I would say we now have a pretty clear understanding that what we think of as nano-rare diseases today are probably much more prevalent than we think. And again, it's just a product of the inefficiency of sequencing. Such a tiny fraction of the patient population has been sequenced. So we don't know. But we do know that every time we have effective treatment, many patients become anxious to get treated. And the point of that is that we are focused on nano-rare patient populations because they're the most urgently in need, and we can afford to do this. But we're demonstrating that what we're learning is going to have a much broader impact on health and disease and healthcare costs, even if we just look at the nano-rare patient populations that we call nano-rare and think ostensibly they are. So, in fact, I think that as we look at nano-rare diseases and nano-rare mutations, what we're learning is that most genetic diseases are composites of multiple mutations in one or more genes. ALS is a very good example. ALS was once thought to be a disease that varied widely in age of onset, severity of disease, types of symptoms, but we now know that there are mutations in multiple genes that can cause what is called ALS. And within a single gene, there may be a very common mutation and then ever more rare mutations. And so we're going to see that pattern repeated over and over again in rare diseases. And if we don't find solutions to the diagnosis and treatment of these extremely rare mutations, then we will leave a large patient population behind, and no patient population should be left behind.
Fascinated by genetics, but feel overwhelmed reading lots of articles? Check out our podcast, DNA Dialogues. It's the official podcast of the Journal of Genetic Counseling, where we chat with authors about their papers. We explore topics like the impact of rare disease on families, the intersection of the disability community and healthcare providers, prenatal genetic screening, whole genome sequencing, and so much more. From navigating complex testing decisions to building trust with diverse communities. Listen in as we unpack the science, challenge assumptions, and celebrate the human connection at the heart of genetic counseling research. DNA Dialogues, a podcast where the blueprint of life meets intimate human conversation. Search DNA Dialogues wherever you are listening to this podcast.
I think another important lesson is that the nonprofit model in which patients are treated irrespective of their financial status is feasible. I'm committed to equitable distribution of healthcare, and n-Lorem reflects that commitment. And we've been humbled by the support that we've received from many quarters and know that we still don't have enough funds to do all that we could do. Nevertheless, momentum continues to grow, though at a slower pace than the demand, and we're committed to serving patients whether they have money or not. We're committed to that. We're committed to the notion that every sick patient deserves treatment, not just those who have the wealth or the ability to raise the money. And, we're now buttressing our charitable and grant support with commercial relationships, and we can talk about that too. Can we today claim ultimate proof that our model will work? No. I mean, many patients and many families are benefiting from our efforts today and more tomorrow. But to my mind, it's not good enough to talk about doing something about nano-rare patients when patients are suffering. And at n-Lorem, we do things. We don't talk, we do. We do what we set out to do. And we need to continue to find ways to grow our funding so that we can begin to meet the demand that we are experiencing. And it's wonderful and heartening to see the benefit that we're bringing, and deeply distressing that we can't do more. So if you're interested in n-Lorem, we need your help. We've done this not by ourselves, but with a lot of support from a lot of people. But if you care about nano-rare patients, I really have to tell you, you can't sit on the sidelines. You need to help us in any way you can. And everybody can help. So those are general lessons. How about nano-rare mutations and diseases? Well, nano-rare mutations, not surprisingly, are spread throughout the genome. That's not surprising, but now we have the data. We can say that we can see nano-rare mutations in essentially every gene family. All the different cellular functions, the molecular pathways every pathway has the potential to produce significant nano-rare disease. And certainly, based on our initial experience, mutations in ion channels produce a ton of terrible disease, as well as microtubule function, particularly in the central nervous system, but also elsewhere. And because the microtubules are responsible for moving materials to sites in the cell that are where they're needed and getting rid of waste. And so it's not surprising, but it's important information. DNA replication and repair, transcription, lysosomal function, all of these things are highly represented, as you would expect, because these are broad, critical functions that every one of your cells has to engage in to make you healthy. I would say nano-rare mutations can affect any organ. Yes, we are dominated by neurological diseases, but we certainly are seeing nano-rare mutations in the eye and the liver affecting the kidney. And so any gene family, any organ can be affected by nano-rare mutations. And essentially all types of mutations can cause nano-rare diseases. So you can have a mutation in a gene that causes loss of function, the inability to make the gene product, or you make a gene product that isn't functioning well. We certainly have plenty of loss of function mutations in our application pool. Homozygous loss of function mutations, we don't see much. And homozygous means that both copies of the gene are mutated. And the reason we don't see these much is they're typically fatal to the fetus. Most of our loss of function mutations are heterozygous. And in heterozygous circumstances, whether it's loss of function or gain of function or whatnot, you have mosaic cells, and in which you have a normal gene and a mutated gene, and normal RNA and mutated RNA, and normal protein and mutated protein. And generally, antisense technology is the only technology that can be specific enough to address the problem by treating only the mutant form of the RNA and protein. We see many mutations that are called toxic gain of function mutations. That is, either that there's a mutation in the gene that results in a protein that is hyperactive, or results in a protein that does something it was never meant to do or shouldn't do. And in many cases with toxic gain of function mutations, we see proteins that do things and go places where they shouldn't. And as a general rule, toxic gain of functions tend to result in more severe manifestations than most heterozygous loss of function mutations. Now, we can help some loss of function mutations, but true null mutations we can't fix. So a good many of the patients that we have to decline are true null mutations where no protein is made, no RNA is made that has any chance of working. And we simply can't fix those. We're working hard on solutions for the less severe loss of function mutations where we might be able to upregulate translation. Those are tough for us to fix.
So Stan, when you're referring to these loss of function mutations and toxic gain of function mutations, right? I've heard you talk about gene product and you mentioned protein. So just to clarify, so you're meaning the affected gene is either not producing enough protein or is producing too much protein that's resulting in negative effects, right?
No, not exactly. Loss of function can mean you're not producing any protein, or you're producing too little, or you're producing a protein that is dysfunctional. So you might have the same amount of protein, but you don't have the same amount of activity. Gain of function may mean greater activity that is the traditional activity of the protein, but most often it means you've acquired some other different activity. The protein interacts with the other proteins, or it goes someplace in the cell it shouldn't, or it actually has a new function that is producing a problem. So increased activity, decreased activity, normal activity, or the gaining of new functions that just are problematic. And of course, mutations can also affect the processing of RNA. Remember that a gene is transcribed into RNA, and then the RNA has to be processed to the mature message. And so we see many splicing disorders, and many of these splicing mutations, they can produce almost any consequence that you can imagine. You can make too much to make too little. You can make the wrong protein with the wrong function. So splicing disorders are common, and these are mutations that we can usually address. Also, don't forget that many RNAs function. They have their own functions, and if you have a mutation in a gene that is for an RNA that performs a function, so like U4RNA. U4RNA is a small molecular nuclear RNA that's involved in splicing. If you have a mutation in that disease, you can have a very bad disease. And so here, you have an RNA that's the problem, not the protein. So gene products include both RNAs and proteins. Okay. I would say that most nano-rare patients express severe, chronic, debilitating, progressive diseases. I think this is an important conclusion as it speaks to the enormous impact of nano-rare disease on life and on the cost of health care and on the family. However, I suspect as genomic sequencing is more broadly available, we'll identify many patients who are far less affected and many of these mild manifestations that we simply don't even notice, and we may be able to help those patients even more. So, yes, today, nano-rare diseases are severe and they're progressive and they're debilitating. But there will come a day when we have enough genomic sequencing available that we'll be able to identify many patients that are less significantly affected, but clearly affected in a negative way. And those we should be able to help even more. Of course, the journey to diagnosis today is idiosyncratic. It's long, it's perilous, it's filled with misdiagnosis, mistreatment, misreferrals to the wrong expert, and people give up. And we know that the vast majority of nano-rare patients are never diagnosed. That's still the case. And so we must bring an end to that statement. And we have the means to do it. Genomic sequencing is cost-effective. It could be available as part of newborn screening protocols, and it would change things enormously. Moving on, what are we learning about the impact of ASO treatment on nano-rare patients? Well, first, we have great news. We have now shown repeatedly that ASOs can positively, dramatically affect diseases in the eye, the liver, the kidney, and the central nervous system. Our data show that the impact can be extraordinarily positive in many cases, and that we can see benefit even in patients who have extremely advanced disease. That is really great news. It's surprising to me how much benefit we're seeing. In particular, intrathecally administered ASOs for CNS diseases result in profound observable benefit. We see this in multiple patients with severe neurodegenerative diseases. We see benefits that include reduction in seizures, improvement in movement disorders, improvement in pain syndromes, ataxia, dizziness, autistic symptoms, and even autonomic dysfunction manifested as severe GI distress. We've seen significant improvements. And we've seen significant improvements in patients with very, very advanced disease. That is really encouraging, great news. That means that we should make every effort to treat as many patients as possible. We're quite surprised, really, I am, at how much benefit we're seeing at very low doses with IT dosing. This has caused us to reconsider some of our assumptions about dose and means that we can help patients with doses lower than we previously thought, which, of course, is good news. And finally, we're seeing that many patients with neurodegenerative disease can recover long-lost functions or actually add functions that they never had, which tells us that neurodegenerative diseases, developmental delays, are not necessarily forever. and that the CNS is much more plastic, much more able to recover from a long-term expression of a disabling mutation, much more than we thought. And we're learning this in multiple patients at n-Lorem, and other studies in other neurodegenerative diseases are learning the same thing. So this is a big, important lesson that sort of reminds me of the change in attitude about stroke. When I was in medical school and residency and taking care of patients, generally if a patient had a severe stroke, we gave up. We now know that patients can recover enormously from the most severe strokes. And we're learning the same thing about developmental disease. That's really great news. It just gives so much hope to what we might be able to recover and the kinds of futures we can create for patients. I can't imagine being able to, I couldn't 5 years ago imagine saying that. Today I can say it, and I have the data to support it. That's really good.
Something that's really fascinating to me is the alleviation of autistic symptoms in our patients. So I was hoping that if you could specify if n-Lorem's learnings from these patients can be applied to broader disease communities, like those with non-rare forms of autistic syndrome and ALS.
Well, what we're learning is that the main issues of autism, such as communication skills can be recovered, that repetitive behaviors can be reduced, that anxiety and social interactions can be dramatically enhanced in patients with very severe autistic syndromes. And of course, an ALS is a simpler disease. It's a motor disease, and we are certainly seeing a benefit in many ALS patients. I think as we discover targets that affect autism, and each of the targets is different, we're learning that we might be able to, if we look hard, we might find that the genes that we're working with may be involved in many more patients with autism, and that we could use our ASOs to treat more. But that would depend on genomic sequencing and much better characterizing of autistic patients than exists today. That's a qualified yes, I suppose, Andrew. Okay.
Thank you.
The other important point that we're seeing is that ASOs can result in very durable benefit. We have patients who've been treated for more than 2 years now continuing to benefit. We have quite a number of patients treated a year or longer and are benefiting. And we do not see an increase in adverse events. And so that, too, I think is encouraging. It is by no means surprising that many of our patients have heterozygous mutations in essential genes. So these are toxic gain of function. Something's gone wrong, but they're in genes that are essential. So we cannot cause a reduction in both the mutant and the wild type gene product. And to do that, then we have to develop what we call allele selective ASOs. And that's harder, but we're learning how to do that very effectively. 60% of our patients require allele selective ASOs, and we're doing it repeatedly, and we're seeing real benefits. And so, again, that's very encouraging about technology. And we're working today to try to learn how to do allele selective ASOs better, to be more efficient in the discovery of allele selective ASOs and develop more robustly active allele selective ASOs. And we think that's coming. And so this is an important lesson about nano-rare diseases. It also causes us to think through how would we develop a medicine for a patient population where we require multiple ASOs because of allele selectivity. And so it opens up great opportunities and real challenges. Another important lesson that we've learned is it's possible to create a community for nano-rare patients. I'm really proud of what we've done there. I think the podcast series has been very well received, and our audience continues to grow. I think our annual colloquium is adding real value and bringing people together. The fact that people feel that they're not alone, that there are people to talk to and there are people who care is a really big deal. And so I'm very proud of that and hope that we can continue to grow the audience for our podcast series, and that we can see the community come together in more energetic ways, where the community comes together and works to solve problems that the community sees as worthwhile problems to solve. I think that's the next step. Wasn't clear how well received all of this effort would be, But overall, I'm pleased with where we are. I'm looking forward to continuing to work hard to build an energized, energetic, organized community for the nano-rare patient community. What do we learn about systems and processes? An industrialized process is important. We are delivering great value because we're doing it the right way. And these systems that assure the highest quality at each step are especially essential when you move to sick patients with so little preclinical data. We're also very pleased that the clinical trial process that we invented, which is a modified crossover clinical design, is delivering really valuable data that's reproducible. And in this, of course, what we do is we define our treatment goals, the clinical measures that we'll use, and then during the time it takes to get the ASO ready, we collect data, and then we can compare on treatment to pre-treatment. And we're also learning a lot about how to better use patient and caregiver reported observations. In the past, certainly I tended to dismiss all anecdotal information, but I think with how we're learning to do this, we're really seeing real value in being able to collect that kind of information. And finally, we're standardizing the way we describe phenotypes, the way we describe disease, and so on. And that's allowing us to look at the overall performance of the portfolio in a better way. So a lot of progress there, still a lot to do, but we're really pleased with where we are. And then funding. Well, we are extremely pleased with the support that we've gotten across the board. And that support has allowed us to grow dramatically to the place that we can file 20 to 50 INDs per year. Think about that. We're a tiny little organization. I don't doubt that Pfizer files 20 INDs for new chemical entities a year. Certainly, they're larger than we are. And so that's great. But the disappointing part, obviously, is the demand is growing at a pace that's far greater than our ability to raise money. And so I think it's really important that we're ahead of schedule and making progress on our plan for sustainability. We've already started marketing opportunities that are commercial. We already have gotten 3 deals done that bring in meaningful amounts of cash to us. And so I'm hopeful that we'll be able to supplement what we can raise from grants and charitable giving with commercial revenues. And that will allow us to grow to meet the need in a different way. And this was always part of the plan. It's just nice to see it begin to take place, 2-3 years ahead of where I thought we would be. It needs to, because the demand is just a lot more than I thought we'd have as well. So in conclusion, I think we've come a long way. And we're learning important lessons that will advance our understanding of health and disease broadly, while we're helping patients and families feel better, do better, have a brighter future, think about an opportunity rather than simply the desperate challenges that these patients and families experience. And of course, we have a lot of challenges ahead, and, we'll work hard to overcome them. But we've overcome every technical, clinical, regulatory barrier. And our only really significant challenge today is raising the money to do what we need to do. Of course, we haven't done this alone. We've had tremendous support, and we need more. So we thank everyone who has joined us in this endeavor, and we encourage those of you who are interested to join us. Every dollar, every kind of support that we get matters. It helps us change a life. And so we certainly strongly encourage you to think about our patients. You're not supporting us. You're supporting our patients, and they need our help. So with that, I'll bring this to an end. I hope that I've given all of you an accurate report that is very positive and certainly encouraging compared to where we were 5 years ago. Thanks.
n-Lorem is a nonprofit committed to discovering and providing personalized experimental treatments for free, for life, to patients with genetic diseases that affect 1 to 30 patients worldwide, referred to by n-Lorem as nano-rare. Many of these patients progress and die without ever achieving a diagnosis. This is where n-Lorem comes in. They do the impossible by providing hope, and for those that they can help, free lifetime treatment. For more information about n-Lorem or today's episode, visit n-Lorem.org. Any questions can be sent into podcast@n-Lorem.org. Search n-Lorem on Twitter, Instagram, YouTube, LinkedIn, and Facebook to connect with us. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This truly helps us climb the charts and allows others to find the show. This podcast is hosted by Dr. Stan Crook. Our videographer is John Magnuson of Mighty One Productions. Our producers are John Magnuson and Kira Deneen of DNA Today. Thank you for listening.